Hello, my name is Andrew Shannon. I'm the ultrasound director at the Lakeland Regional Health Emergency Department, and we're going to be talking today about ultrasound guided peripheral IV access. Many of you will be looking at this video because you're going to be going through the credentialing process, and this should supplement any in-person instruction that you have. We'll go ahead and begin with some goals and objectives. The primary goal, of course, is to discuss the indication of placing an ultrasound-guided peripheral IV. I'll refer to this as the USGPIV. We'll review the protocol for placing IVs with ultrasound guidance, and then we'll also demonstrate the technique using ultrasound for IV access. Let's talk about why we're doing this at all. So the rationale for ultrasound-guided IVs, one, it increases the number of spots available to you. You can visualize the vessels that are not palpable or visible on the surface. Two, there's evidence to suggest that ultrasound minimizes the number of IV attempts before successful cannulation. Three, it's possible that with better access, it can decrease the number of times that a CVC or central venous catheter needs to be used. It can decrease some complications, but we'll talk about the fact that it raises the incidence of others, and also it increases patient satisfaction. So the questions that we have when using ultrasound to select veins is one, we need to identify the target vein. We need to also assess to make sure that it is patent. We need to assess its course, as non-branching vessels that are straight are much more easy to cannulate. And then also we need to identify what I call no-go spots, or issues where the veins are too close to underlying or other structures that should not be attempted because of the risk to those structures. So we use ultrasound guidance when multiple blind attempts fail, when we've got ourselves a DIVA, a difficult IV access. This is in fact a term in the literature, and DIVA is defined by a history of 3 or more failed blind attempts, a history of difficult IV access requiring CVC placement in the past, or a history of ultrasound-guided peripheral IV placement in the past. Now, of course, here we can run into a little bit of self-fulfilling prophecy, much like the original Top Gun. If you become too reliant on missiles, in this case ultrasound, then you lose your dogfighting skills, which is to say your blind stick skills. So we want to be careful that we are still able to practice our blind stick skills in a pinch, because ultrasound may not be appropriate for all situations, and we don't want to become dependent on it. So what equipment do we need to use for an ultrasound-guided peripheral IV? Well, I like to think of it as, at this point, we're doing this procedure because other attempts have failed, so we need to take it seriously, and we need to make sure that we have all the equipment that we need to create the best situation that we can for placing the IV. So all the materials that you would need for just a regular IV, or for drawing blood, whatever the indication is, and then also the things that you would need to position the patient correctly for you. I consider a stool important, because sometimes you want to sit and take your time with this procedure, because very often this is kind of a rescue procedure. You're going to obviously need a horizontal surface to stabilize the patient, and you're going to need some of your longer IV catheters. The other equipment that's important in terms of using the ultrasound safely for the patient would include an ultrasound probe cover. Here we have 2 different types of these viral barrier films and sterile gel. Because you're going to be cannulating the vessel, you don't necessarily want to use the larger gel bottles or multi-use gel that is not sterile. And then test your might. You're going to need an ultrasound. So what we have here at Lakeland include the types that you see on the screen there, but any ultrasound using a linear transducer or the superficial transducer is probably your go-to. So importantly, when we're thinking about having the ultrasound available, we want to make sure that we do the things we need to take care of the equipment. So right now, the ultrasound machines that are being used at Lakeland are also being used for diagnostics, including by the different physicians on the floors. So as a result, the machines will have access to the patient work list, which includes patient information. As a result, there is a login that is required on all the machines. Every machine can be used in an emergent situation, but without logging in or putting in patient identifiers, by simply choosing the guest or emergency mode, which you'll see on the screen when you start to boot up the machine. So here's an example of that using the Sono site, where you can just click the blue guest button there and bypass any need to log in. If this is done, and you're going to be saving patient information because you'd like to link that procedure to the patient's medical record, then you will have to have a login, and we can talk about that later. Importantly as well, we want the machine to work. One of the things that people tend not to realize is that there are fibers in the cables of the ultrasound themselves, and if those fibers are frayed or bent or torn because of running over the transducer cord with the wheel, because of tying it in a knot, because of folding it too acutely, then the ultrasound probe will cease to function. So what we need to do is we need to make sure that we use the little cups that are available on the ultrasound machines to hold the quite expensive transducers, and we need to use any hooks to keep the cords off the ground so that we're not running over them and causing them damage, which will require a replacement. So again, just to reiterate, and perhaps if we had to cut that last section off, remember to make sure that your transducers are secured, not falling to the ground, not at risk for falling to the ground, and that they're up in the cups designed to hold the expensive transducers, and the cords are up off the ground. Similarly, we want to try to avoid using cracked or broken transducers that are not watertight. There's unlikely to be a risk of electrical shock to the patient, but it's probably more likely that you can cause a short that will damage the machine itself and not just the transducer. And remember that the ultrasound-guided peripheral IV placement is a clean procedure. We need to use a transducer barrier cover and a sterile gel. Bottled gel should not be used. So transducer, we're going to use a linear transducer. You can use a hockey stick, micro transducer, sort of pick your poison. I tend to use the word transducer as opposed to probe because that little guy is what I think of whenever I hear that word. The ultrasound screen. So in general, you'll come up to the machine, you'll be placing the transducer on the patient looking at the screen. So we want to set that up correctly. You'll choose vascular, venous access, nerves, superficial, whatever setting you like. Whichever setting you get comfortable with in terms of seeing the needle on the target is fine. There's nothing magical or special about the factory settings. You'll adjust the depth to make sure that what you want is in your field of view, and then we can go ahead and use the zoom features as needed. The big important knobs that you'll need to know are the near and the far gain, and gain in general, and basically that'll sort of increase or decrease the superficial or the deep brightness on your screen for a better picture. Many of the machines will also have the ability to add a center line, which helps just sort of make sure that you know what the center of the image is. So here we'll use the words probe marker or screen dot to talk about laterality on the ultrasound transducer. There's a little insignia on this screen to sort of the operator's left-hand side of the screen. That dot will actually correspond to a particular marker on the probe. So if I'm holding the probe with the probe marker to my left, the operator's left, then I'll always be set up to have success when looking at the machine doing a procedural ultrasound. So here we're applying a little bit of gel just as a quick check, and you can tell just by tapping on that sort of side there, I can see movement on the screen on the corresponding side, and that is sufficient to let us know which side is which. And when we're adjusting gain, all we're doing is we're literally just holding down the little gain button here. The screen gets brighter, the screen gets darker. It's the same as the brightness on your television. When we're adjusting depth, again, we're hitting that button to sort of increase or decrease our field of view, kind of like Google Earth, zooming in or out. And we'll see on the side that there is a scale for our depth that corresponds to 1 centimeter, 2 centimeters. It just depends on how deep our screen is. In general, most of your targets are going to be above the 1 centimeter mark, so you don't need to go particularly deep. And then we're going to try to choose which vein we want. We want the vein to be easily compressible. We want it to be straight. We don't want there to be any valves in the vein, if at all possible. We want the diameter to be relatively generous, and we want the vein itself to be close to the surface. And here we can see we're thinking about this vein here. We're compressing the vein to make sure that it is free of thrombus, and also to make sure that it is a vein. Some cysts or other fluid-filled structures can have that sort of black anechoic appearance. Here we're also putting on a little bit of color, just to sort of see a little bit of some color flow pattern. There's the other spontaneous speckles, which aren't as important as that sort of blue color in the middle there. The color of the color flow signal doesn't matter. It can be red or blue. It just depends on the angle of your transducer. As long as you've got some of that flow signal in there, you should be fine. And then again here, using a phantom, just again compressing. And then again here, we've got some compressible vessels in short axis. We're going to rotate our transducer to 90 degrees to look at the veins in the long axis. And as you can see here, a tube in short axis is going to be a circle, whereas that same tube in kind of long axis is just going to be those two little lines. So it's going to look like that linear structure on the screen. Here, we've got a vein and an artery on the screen. We're going to choose that vein that is at about 0.38 centimeters in diameter, AP, anterior, posterior, or deep. And then we're looking to see that the depth of the vein is around less than 1 centimeter, which is what we're interested in. We'd like to have enough runway of the 3 centimeter sort of long straight segment of vein, just so we don't get into trouble there. We're going to choose a catheter. Our catheters come in different lengths. In general, because catheter length has to do with flow rates, a shorter catheter is best for increased flow, and the longer catheters will decrease the flow rate that you can achieve. However, if you've got a patient here, you can't get access, and so you've come to an ultrasound-guided IV, I would suggest thinking about whether an ultrasound-guided IV is the best choice, because you are going to need a long catheter to get to those deeper vessels, and maybe a different access is required if you really need to put in that volume. Maybe that patient needs that introducer gauge type access because of their volume flow rate requirements. And so we got a little bit of math that we need to do here. Thinking about the isosceles triangle at 45 degrees angle needle entry, the segments B, distance from the transducer, and A, distance to the vessel, are approximately the same. Let's hypothetically say that's about 1 centimeter. So that would mean that C, the hypotenuse, or the track of the needle and catheter, would be about 1.4 centimeters. But again, that's just to get to the vessel. It doesn't have anything to do with getting into the vessel and sort of threading along the vessel. So that's the minimum distance we would need to reach the vessel. A lot of those calculations can be seen here. And why is that important? Well, it's important because we want to make sure that enough of the catheter is actually within the vessel that it's going to be useful and it's not going to just sort of wiggle out. So here we're talking about approximately 2/3 of the catheter length in the vein would be the ideal goal. If that's the case, our catheter length, just in our hypothetical example, should be relatively long, 4 centimeters, if we just sort of be very, very conservative. Now, obviously, we don't always use a catheter that long for that depth of vessel, but this sort of brings into mind the idea that we need to be thinking about using the longer catheter lengths for our vessels. Here we've done a little bit of that math for you. We can see that on the basis of vessel size and vessel depth, that various catheters are recommended. So it's important to bear this in mind when you're choosing your catheter length and thinking about trying to go for those deeper vessels. You just want to make sure that you've got enough catheter in the vein at the end of the day. You can always double check that on ultrasound after the fact, but here are some of those recommendations. And here just another group of calculations thinking about catheter length with some different assumptions. But the important thing to recognize is that if you're looking at anything around the 1 centimeter mark or so, you're going to be thinking about something that tends to be a non-standard catheter length in most EDs. We need to make sure that the probe is clean, that there's no adherent adhesive or anything else to the transducer. We can use whatever the hospital recommends. In this case, we're using the gray top Sani wipes to ensure that there's no visible soiling of the transducer and that we have a dry time there as well. It's about a 2-minute dry time is what's recommended, but essentially you want to make sure that the transducer is wet from the disinfectant, and you do this first before getting your other supplies so it has a little bit of time to dry. Further, the ultrasound gel that you use for your pre-scan, you're welcome to use the non-sterile sort of multi-use gel bottles if you'd like, just to sort of take a look and make sure your vessels are good. But when you're actually doing the puncture, you want that to be the sterile gel so that there's no question of cross-contamination. Similarly, for a central line or a PICC line, you might use the sterile sheath, sort of like the long, totally enclosing bag that we put the transducer in. For most ultrasound-guided IVs, we don't necessarily recommend that. We recommend a film barrier. Traditionally, people have been taught to use a tegaderm. There's various reasons regarding the pore size and the FDA approval status of tegaderm for this indication that we don't recommend at this time, though you may well see some people doing that. We have a different option, and that different option we'll talk about. Nevertheless, when you're putting a tegaderm or any film barrier on, here I like what we're doing in terms of making sure the sides are folded there nicely, but you'll also see that we kind of ran our finger along the edge of the film. That's not necessarily something that I would recommend doing, in particular if we're doing this for any other indication like a joint or something like that. But we'll sort of take a different way to look at it. It's not the end of the world, but it's not what I'd recommend. So what we're using are these commercially available barrier patches. They happen to be called sheaths, sheathies as their brand name. It's a little bit unfortunate because you can get some confusion with that big central line sheath bag type setup. But we have these adhesive patches. Essentially, they have a sticky side that goes on to the transducer. The non-sticky side starts as sterile, and then we use our sterile gel with that on the skin. And this is how we would apply that, kind of like a steri-strip, where I make sure that one side is like nice and well adhered, and then you sort of pull across. We'll see what that looks like here. I want to make sure that that doesn't touch anything off screen there. We'll make sure that we've got a nice sort of stick adhesion there. We'll pull it taut, and it's not so taut that it wrinkles, but taut on that other side, and now we're ready to go. And we'll see one more time, just being careful not to touch sort of the business end of the barrier film, making sure the sticky side is toward the probe, making sure you've got some nice grip there, and you're just sort of putting it across like that. The center line that we see here, many of these transducers have them, is what corresponds to the center line on your screen. Some transducers don't, but most do. So here we see the centered needle in the probe and the vessel in the center of the screen. You can drop that line if you would like to. Obviously, there's no sterility going on this picture for demonstration purposes. So this, obviously from 5-minute Sono, we see the vanishing target sign. Here we have sort of the mock-up of the transducer and the needle and the skin. We have the vein in long axis, and then over in the top corner we have the vein in short axis. So in short axis, the transducer is going to look at the vein and see a circle. It's going to look at the shaft of the needle and see a little dot, and that's what we'll see in short axis. In long axis, we'll see sort of everything coming together. What we want to do is what's called the inchworm technique, or also Wayne Gretzky was famous for saying skate to where the puck is going to be. We always want to make sure that the plane of our image, which is generated by the transducer, precedes our needle tip, and that sort of lets us know that the dot that we're seeing on the screen at any time is always the needle tip. How do we know that? Because if we advance just a little bit more, it disappears because it's no longer on the screen. And then you can always tell that the dot that you're seeing is the very extreme end of the needle, because if you go any further, it disappears. And then you move the needle into that empty space, you'll see the dot reappear, and then you'll move your transducer proximally along the arm or away from the shaft of the needle and yourself usually, and then you'll enter that needle into that space that's created, and we'll see that here in a few different ways. Needle enters that field of view, we see it there as a dot, we see it as it sort of progressively moves in, and then boom, we find it in the vein. We'll see that potentially again. And you can move the transducer physically up the arm, or you can just sort of angle it depending on how much runway you have. And that's sort of the vanishing target, or the inchworm technique, where we want to move that transducer as soon as we see that needle at all. Move that transducer, and you don't need to take as big steps as they're taking there, but we're moving that transducer as soon as we see that needle. Here, this person is kind of following their needle tip. You can see that their transducer is sort of running to catch up to their needle tip. That's not what I would recommend. You want to lead the needle and you want to sort of always see nothing, which is to say not see your needle, and then use your needle to enter into that space. We're going to see that one more time here. So, boom, as soon as we see that dot, move that transducer, either by fanning or by translating the transducer up the arm or proximal on the patient, and you'll sort of see yourself walk down the vein. So I have seen a lot of people talk about the fact that bouncing the needle or jiggling, wiggling the needle is a good idea if you don't know where it is, and look for the tissue deformation. To a certain extent, yes, you will see tissue deformation if you move the needle. But the other thing is, if you imagine you've got a sharp stabby thing in the patient and you're not sure where the business end is, do you really want to sort of bounce that a few times and sort of turn the, kind of aerate the carotid or whatever the deeper structure is? I don't think so. So I wouldn't recommend that. So bouncing, jiggling, wiggling, professional life, not so much. Personal life, that's on you. So what we'd recommend is, if you're going to use sort of the motion of the needle to determine where your needle is, like which of the sort of things that you're looking at is actually your needle, then go ahead and move the needle back some. Okay. The idea being that any movement that you see, if it's easier to see that movement, great, go ahead and use that. But use that movement in the withdrawing motion, because anything that you've cut or any structures that you've gone through, you've already gone through them. Whereas sort of that kind of bouncing is maybe not the best thing to try. So try that the next time. Here we're going to again watch this person translate their transducer proximal on the arm away from their needle as they move and try to cannulate the vessel. And now let's go ahead and see what that looks like with the ultrasound. You can see that they're moving their transducer all the way to the point where essentially their needle disappears from view. And then once they get into that space, they're moving a little bit, but you always want to sort of see the empty space where your needle is going. You don't want to sort of fixate on the fact that you can see your needle. If you can see your needle while you're moving your needle, you're not seeing your needle tip. Mind's blown. I can hear it even in this video. Okay, so why do we care? This is what we want to avoid. You don't want to do this backwalling or this passing through the plane where you're seeing the dot in sort of the transducer visual plane, whereas the business end is further proximal and deeper. That's how you get into trouble. So what we've been talking about here has been the out-of-plane approach, which is to say your needle is coming out of plane into the plane of vision. There's also what people will refer to as the in-plane approach, which is where your needle tip is always in view because you're in sort of the long axis of your needle. And very often you'll be in the long axis of the target vein, but that can be less important. So here's what that would look like. Your vessel is there in long axis, that sort of tube, and you're seeing your needle tip and the needle shaft come in from the side of the screen in long axis. You're sort of a little bit out of plane, a little right-left here, but you're basically seeing the tip, which is what you care about, and the shaft coming into view. And then you're actually seeing here in this model them going ahead and putting some flow into the model there. The advantage of this technique is obviously that you see the needle its entire path as opposed to trying to inchworm along. The disadvantage, of course, is sometimes it's a little bit difficult to get the target needle plane orientation in your head correctly. But if you practice it, it's actually pretty useful. So one of the ways that you can use this long axis view, even if you're doing the transverse out of plane approach, is you can turn your transducer while you're there in long axis and just confirm that your needle tip is in the vessel itself. So basically this is a demonstration of turning the transducer. You can tell it sort of slid off of it as they turned, but then they had to correct. That's fine. And then obviously you want to be able to hold the transducer with your fingers on the patient so that you're not putting pressure with the transducer probe. Here this is being done for demonstration purposes. And we'll see essentially what that looks like as we try to sort of keep it in view. As we go from short axis to long axis, we can sort of see that we're transitioning there. Remember, just like you would for a blind IV, you want to enter the vessel, and then instead of kind of continuing and hitting the back wall, you want to, as soon as you get flash, you want to flatten out and then continue along the vessel. If you thread too early, as you saw on that top screen, you'll have flash because the bevel will pierce the vessel. You'll start to have some backflow of blood, but the plastic is still outside the vein. So it's very difficult to advance, and that's not going to work. If you advance at the same angle, however, then that's much more likely to backwall the vessel. So essentially, once you get that flash, that's when you flatten out, right? You change your slope, your rise for your run. So by changing that angle, you'll be able to get a little bit more of your catheter seated in the vessel before you even have to take the needle out. And then, of course, remember, just like with blind IVs, you don't want to pull your needle back. You want to advance your catheter in on the off chance that you have yourself just barely in the vessel wall. You want to make sure that the catheter advances down the line of the vessel and it doesn't sort of make its way outside of the vessel. And there we sort of see those catheters just sort of shooting off those needles there. And that's what we like to see. And then importantly, you don't want to sort of advance your catheter, pull it back, try again, all that, because you could end up with something like this, especially if you have a steep angle. And you don't want to have someone fish a piece of plastic out of the patient's lungs, or even worse, if they have a PFO, out of their cerebral arterial circulation. So you don't want to shear the end of your catheter off and sort of embolize that down to the patient. So if you advance and it fails, don't pull back and try again. As tempting as that is, just be prepared to abandon that catheter and choose another one. So that has to do with your setup. Once you've got the catheter in the vessel, you thread it into the vein, attach the port, draw blood, whatever you'd like to do, secure the catheter as you normally would, flush it, make sure it flushes well, and then dispose of all your sharps and supplies. And then this additional step, clean the ultrasound, take that barrier off, clean it down with the gray top wipes here at LRH. Put it back where you found it. Just be nice to the next person who's got a patient that they're struggling with. Put it back where it's supposed to be and plug it in. Now, once all that's done, the last step that I recommend is something that I call the proximal glitter check. Whenever you've got a catheter in the vessel, and whenever you can sort of flush the catheter, or you can set up just regular IV fluids, honestly, you'll often see some turbulent flow in the vessel proximal to where that enters the patient. So basically, when all of your other steps are complete, you can grab with the non-sterile gel with a non-barrier protected ultrasound. Just look proximal on the patient, whether that's the right ventricle or just further up the arm, and go ahead and flush that catheter, and you'll be able to see, as you see in some of these videos here, some of that turbulent flow, sort of some of that flush that sort of just creates this sparkle, or what I call glitter. You'll see that in the proximal vessels. And why is that important? It's important because not infrequently we'll get good blood flow initially when we're putting these deep catheters in. And then we'll be able to push fluid through and we'll say, all right, well, it flows nicely. But the problem is, because these vessels are deeper, we don't have that tactile feedback of the vein blowing. We can't see it swell up, and we can't see it rise to the surface. And it's not as painful, quite honestly. And the reason for that is, once you're sort of relatively deep to the point where you're using an ultrasound, you could be in the muscle, you could be in the fascial planes, you could be in the space, the sub-Q space, where the patient just doesn't have a good sense, or you don't have a good sense that what you're doing is you're just flushing in fluid and dissecting those planes, and you're not actually in the vessel at all. So the problem there is, one, you haven't been successful, but two, if you try to push IV contrast to do that, if you push certain significant medications like pressors or RSI medications, you're going to have an issue, because you're basically giving sub-Q at that point medications as opposed to anything in the vessel. So this proximal glitter check is one of the best ways to go ahead and check for that. Here, for example, you'll see someone pushing a little bit of a flush, and you'll see in that right ventricle a glitter there in the right ventricle of the beating heart. And then on your left side of the screen, you'll see that at around the 2 centimeter mark or so. There's a vessel there. You get a little bit of a flash, maybe a little bit of some air, but essentially some of that glitter there, so that you know that between the point of your catheter, which is somewhere down the arm, and higher up where you're checking with your ultrasound, that's got good communication. You're flushing through. The tip of your catheter is in the vasculature, and when you flush distally, you can look and see proximally that glitter, and it feels good. It's nice to see. Okay, so in general, this is what we're looking at. Blind attempt times 3, or whatever the standard is. If the patient says no, you need an ultrasound, go ahead and listen to them. It's fair enough. But essentially, it's failed. So you've got a new DIVA. You notify the doctor. Put this in here in situations where you're working relatively closely with the physician, such as in the emergency department. But you can establish sort of like the protocol or sort of whatever the process is on the floor. It's fine. So the new DIVA. So try an ultrasound guided stick. That sounds great. And then after that first attempt for this sort of rescue procedure, we need to have a talk, because now we're talking about sort of using and potentially blowing some of these deeper vessels. So the idea at that point, I would recommend reconsider whether or not an IV is totally necessary, reconsider whether the physician or someone else needs to put in an EJ, whether or not a central line actually is in the patient's best interest, before trying to decide and go ahead and do another ultrasound-guided IV at a different spot. It's fine to do that, but just be aware that as you sort of use up more proximal spots, you're making it more difficult to use the more distal spots or anything like that for the patient. So just be aware that each ultrasound-guided peripheral IV attempt is using up some valuable real estate. So let's make sure that we're doing what's in the patient's best interest. So parting pearls, obviously adjust the gain if the image is too dark. If you lose track of your needle, slide that transducer all the way back to your hub, and then sort of slowly advance once you've identified your needle shaft until you see it disappear. If you've got a bunch of sort of hyperechoic materials in the superficial, don't bounce. Try to see about pulling back and looking for that movement. Adjust your direction in real time if the needle appears to be missing the vein. So as you're sort of inchworming down, if you find yourself veering to the left, that's fine. Come on back from where you were, readjust, and sort of continue in slightly different trajectory. And then you can use the long axis views and use that post-cannulation proximal glitter check to troubleshoot and just make sure that the line looks good. So some of the pitfalls, obviously avoid hitting an artery. The veins tend to be non-pulsatile and compress easily. If it's not compressing very easily, it could have a clot in it, or it might be an artery. Pulsatility isn't always super obvious, so just be aware that that's something that you want to double check. You want to choose a straight non-branching vessel. As you sort of move proximally and inchworm up, understand that you're entering the skin here, but you might enter the vessel here. So you want to make sure that that all looks good as part of your pre-scan. And then avoid thrombosed veins. So again, ensuring that compressibility on your pre-scan is important. So if you do manage to hit an artery, first check to make sure that no one needs an A-line. A little bit of a joke there, but what you really want to do is remove the catheter, apply direct pressure, and then just notify the person responsible if needed. You're usually going to want to hold pressure for a couple minutes. I had an attending who told me that the amount of time you hold pressure is about 2 minutes after you think you're done holding pressure. That's how long you hold pressure for. Notify the responsible provider if you're unable to cannulate after 3 blind attempts or after 1 failed ultrasound-guided IV. You'll develop a practice pattern for this, but those are some sort of rules of thumb that I have. Sometimes if the screen is frozen, it's because the freeze button has been pressed. I've seen that be the issue. And then check to make sure that you're not going to lose power in the middle of the procedure, and that the cord not only is in the outlet, but also is plugged into the machine. Sometimes that connection gets loose. So our IV credentialing process is sort of outlined here. I'm sure that your unit leadership will help you with any credentialing that needs to happen. And this is sort of our check-off competency sheet. It essentially describes the process that we've talked about. You can pause the video and take a look at that as you like. Here it's a little bit zoomed in. And again, the steps of putting in an ultrasound-guided IV. And then the goal one day, certificate of completion, completed the ultrasound peripheral IV course. That's what we're shooting for here. So here are some of our references. I'd like to thank Dr. Duran Goering of University of Florida, Jacksonville, who was responsible for some of the animations that you saw here, and was sort of fundamental in their ultrasound-guided IV and midline program there. I'd like to acknowledge Dr. Avila of 5 Minute Sono for some of the videos that I cribbed there, available on the internet, and then also Dr. Shaw team at University of Washington. So if there's any questions, please do let me know, and happy scanning.